I recently moved from the rich half of Texas to not so rich half of Texas 4 months ago. And I'm going to piggyback on what was being said earlier by Tanya. So access disparities exist, not just that part of the world, but also within America. One center on this side of I-35 of Texas has done 1,100 cars, whereas not a single one has been done on the other half of the Texas that pretty much feeds America. So I think the acquired land, the home ground, work needs to be done on both sides of the aisle. So now I was asked to cover aggressive lymphoma relapse refractory setting. And then I was reminded to give a general overview of cell therapy movement across. So in 20 minutes, I wasn't certain how I can do all this, but I'll try my best. So some off-label usage, some investigational usage. These are the 4 CARs approved across CD19 targeted agent across lymphoma and myeloma. And then when we talk about relapse refractory aggressive lymphoma, we do have CD20 targeting bispecifics. The bottom one is not approved by the FDA yet. BLA sits with them, although it's been approved by European medical agencies, etc. So we'll start out with safety, efficacy, some boring mechanism of action. I'll try to whiz through that quick, and then available data for emerging CAR T-cell therapy in aggressive lymphoma. And then talk about precision-based medicine and personalized treatment strategies to allow escalation and de-escalation within DLBCL space. And then how MRD and NGS-based platforms are getting incorporated into clinical decision-making. And then we can close out on a Pakistani twist. So I think the general theme is historically we treated the cancer, either chop it off, burn it, zap it, poison it, or wait and watch, let it grow, and then do the exact same exercise. Scientific advancement allows, really over the last decade and a half, allowed investigators to harness the powers of innate and adaptive immune system. T cells were initially, checkpoint breaks were released, and then T cells were engineered in a way that they developed almost something which is orthogonal to Darwinian evolution. They were able to have self-perpetuating infectious anti-tumor activity. So kind of summarizing, the focus has been on efficacy. At the same time, I think the goal as I see it, and certainly there are senior investigators here who can certainly correct me here or disagree, the focus has been on toxicity, and during the course, efficacy continued to get better. So we'll take a few examples before we dive into cell therapy and DLBCL. So chemo-free regimens giving way to lesser and lesser toxicity in CLL, in AML, in ALL, in DLBCL, in myeloma. So then targeted immune-based therapeutics, then cellular therapy. So you have conventional CTLA4, PD1, PD-L1, LAG3. Then you have engineered, non-engineered T cells. First you had manufactured, then now we have flurry of in vivo allogeneic off-the-shelf products. Then you have precision oncology. So in solid tumors, you identify a driver mutation, sample the tumor. If you have an inhibitor, you use it. If you don't have it, you take it to the lab, develop, partner with industrial partners, or use your own NIH or non-NIH funding and develop a drug within your lab, then take it to the lab. So paradigm shift, let's take a few examples here. Chemo-free regimens, lesser toxicity, same theme. So Dr. Kantarjan Anderson, he designed this. So we saw that when I started medical school 2003, that was back in Karachi, it was all UCAL12 or hyper-CVAD. So Philly positive ALL, there was no, imatinib was approved in 2003, the same year when I started medical school. So then hyper-CVAD plus imatinib. So overall survival increased by about 12-13%. Then came the second generation, then came the third generation. So last year, New England Journal paper from Robin Foa actually clearly outlines that. Then finally, they did away with hyper-CVAD and they added blinatumomab plus ponatinib. And then the overall survival is not mature yet, but you have a cure rate, overall survival rate of about 90% at 3 years. So during the course of trying to get away from toxicity, you ended up improving efficacy. Similarly, so it took, I don't know, 2 decades to get rid of R-CHOP. The most toxic version, the chemo was vincristine, Oncovin. So they dropped this, added an ADC, and then there are whatever number of trials underway, polar R-CHP plus X, polar R-CHP plus Y, trying to move that needle towards lesser toxicity and increasing efficacy. Myeloma is a great story to tell. So again, I'm not particularly old and I'm not particularly young. So right about entering my 4th decade, when I started medical school, myeloma was treated with melphalan and PRED. And I had pursued oncology based on inspiration from one of my mentors who's also a graduate of the same school, who had just returned to start a transplant program at that uni in Karachi. So I was on the phone call with him last week. He reminded me, bro, we used to treat a myeloma with melphalan and PRED. And the time from diagnosis to death, aka median overall survival, was under 2 years. So, and then 2 weeks ago, in fact 10 days ago, International Myeloma Society met and came up with the definition for cure for myeloma. It's a hard definition, but we are curing it within our lifetimes. I think this is phenomenal progress. Median overall survival for standard-risk myeloma is in excess of 17 years. So this is basically drug development directly translating into patient outcomes. And then Cartitude 5 and 6 will move carviciltocel into frontline setting from second line first relapse, and then Karma 4 and 9 are intending to move the other BCMA targeted product, ide-cel, into frontline setting as well, head-to-head with autologous transplant. CLL, and I'm going to skip here. Dr. Siddiqui gave a very nice overview. So FCR was the name of the game, then single agent BTK inhibitor. And when I see my patients with CLL, I tell them, look, the non-TP53 mutated, TP53 mutated, it's hard to treat them with fixed dose. So I put them on a novel BTK inhibitor or zanubrutinib, acalabrutinib, and I tell them, look, now go and take care of your diabetes and blood pressure. CLL is probably not going to do anything until it relapses. So, okay, now DLBCL, aggressive lymphoma. We see that non-Hodgkin lymphoma is the most common hematologic malignancy worldwide. Total burden in is excess of this big number. And when we kind of compare it with other tumors, we see that survival rates could certainly be improved. I mean, survival rates for thyroid, prostate, even melanoma, non-metastatic melanoma are better and superior than DLBCL. When we divide it by T cell, so T cell we know don't do well anyway. So right from the outset. So we really need to think about, there's no second relapse, third line standard of care in any T cell lymphoma anyway. So clinical trial is really the way to go. Now, DLBCL is probably, we can see that there's room for improvement. Some of the others are actually doing better. So I was asked to kind of restrict to relapse refractory DLBCL, which means below the orange line. So upfront therapy, you have IPI 2 or above, ABC, activated B cells, cell aversion subtype, bulky disease. I would tend to, even without those, I tend to prefer polar R-CHP in my practice over R-CHOP. Or you have high-grade B-cell lymphoma, doublet, triplet, then the game changes entirely. And then relapse refractory, if they're early relapse, the book says transplant, CAR-T, Late relapse, which means beyond 12 months, then you have room to consider autologous transplantation. This was the Scholar 1 study that really set the premise for CAR T. So this is pre-CAR T era. Survivals are dismal. We can clearly see 2-year and 4-year overall survival rates are 20% and 15% respectively, overall survival. This is pre-CAR T era. Now, so the two studies both showed that if you, in first relapse, a second line setting, you could do consolidation, salvage chemotherapy, followed by consolidation autologous transplantation. You do improve survival outcomes. So 32% to 53%, so about under 20% on both sides. Whatever salvage regimen you choose, doesn't matter, R-GDP, R-ICE, R-DHAP, doesn't matter. Both CORAL and NKIC CTG studies demonstrated that consistently. Then came the CAR era. 2017, earlier you had the pediatric ALL T-cell approval, followed by October 2017 axi-cell approval in DLBCL late line. And then the door opened. Quick basics. I was told that this is primarily addressed towards community oncologists. So when we speak to fellows and residents, kind of keep it basic. Chimeric antigen receptor is basically a chimera, head of a line, back of a buck. And why is that? Because it is a hybrid of a B and a T cell. It retains its native T cell receptor, and then it acquires short chain variable fragments so that it acquires B cell properties as well. And why did we need to do that? We can kind of look at this real quick. So we know that B cells can recognize tumor cells by themselves. T cells can't. You have to process the foreign antigen, and then that has to be presented in conjunction with MHC, class 1, class 2, and depending upon the type of foreign pathogen, whether it's viral infection or cancer. Cancer was smart. They recognized this. So they bypassed and they overcame. So one had to be orthogonal to the evolutionary process and add B cell properties on top of an endogenous autologous T cell, and that's pretty much what happened. So you see, this is one of my former mentors at Penn. This is a slide board from him. You can see that the nasty tumor cell, and then you have native T cell receptor intact over there, and then you have your CAR protein targeting the respective tumor antigen, BCMA in myeloma, 19 approved in lymphoma and leukemia. Manufacturing process is cumbersome. Optimal patient selection, you apheresis the right type of cells, send them to the manufacturer, or if you have a GMP facility in-house, then you can kind of do that in-house as well. Academic CARs are manufactured that way. Now, there's CAR transduction. Americans like it viral way. I did some of my postdoc in Singapore. We used to do it LNP and messenger RNA, and Chinese still continue to do that work. In vivo CARs are based out primarily on lipid nanoparticle. So there are multiple ways of achieving the same goal. So you have enrichment and activation of T cells, then you have CAR transduction through a lentiviral vector, and then you have expansion. You enrich them with IL-15, IL-2, proliferate, let them grow, and then collect and sort the right subset of CD4 and CD8 cells, put the patient back on in the hospital, clean out the marrow a little bit, allow homing to happen, give them fludarabine, cyclophosphamide, lymphodepletion, and then infuse the CARs back. So, busy slide, but one table kind of gives you all approved CARs in lymphoma setting. These are some regimens which are approved in second line and beyond DLBCL setting. We have non-CAR options. So in DLBCL, CARs, as the natural progression is in terms of CARs approval in lymphoma and myeloma, they start out late. In myeloma, they started out after third relapse, fourth line, and then moved to first relapse, second line. In lymphoma, they started out third line, then moved to second line. So in third line, there were 3 studies. One of them was my former mentor's here across the street. He did Zuma-1 axi-cell study. We also did that back at the medical college when we were there, participated in the study pretty significantly. The data read out, all of these were early phase trials. All CARs were approved based on single arm studies. Until now, we are trying to put them against the standard of care right in the frontline setting. So FDA mandates comparison to the current standard of care in the frontline setting. For example, if you want to trump autologous transplant in myeloma, you have to put your CAR head to head. You can give induction 4 cycles, DVRD, but you still have to put them against the current standard of care. So the data was so promising. Accelerated approvals went, overall survival matured, then they had full approvals. So Zuma-1 read out, Juliet read out in the favor of T-cell, Transcend Lisa-cell data read out. We see that, pretty heavy pre-treated population there, and then the overall survival was in excess of 59%. Juliet in T-cell, we had again median prior, over half of the patients had received 3 prior lines of therapy, and then 1-year overall survival was 50% in all patients versus 90% in those who achieved CR. So achieving early CR is important. And Transcend Lisa-cell data, primary refractory 44% and 1-year overall survival 58%. While we are on Transcend, it's an honor. Transcend CLL study was led by Dr. Siddiqui, and she was the first author in Lancet paper. Dr. Siddiqui, Tanya Siddiqui, she's in the building. It's a great honor for all of us. Now, CAR-T in third line, so now the 3 CARs approved. How do we, so Scholar 1 clearly showed in pre-CAR-T era that barely at 4-year, your survival was 15%. How did we start doing with CARs? So roughly over a little over a third of patients with relapsed refractory large B-cell lymphoma achieved long-term remissions with commercially available CARs as third-line therapy. We talked about these 3 studies. Now step forward, second line, first relapse. Somebody relapse early, early meaning under 12 months of first cycle, day 1, cycle 1 of therapy of DLBCL, CAR. Primary refractory disease, CAR. A lot of, you speak to 10 clinician scientists doing lymphoma, probably 5 of them will tell you that they do CARs anyway. So CIBM TR data now shows that autos since 2018 have gone down like this, and at the expense of CAR worm really picking up. So the cleavage between the 2 worms is deepening. Now, well, let me just, I can't go back anymore, okay. Zuma-7, second line, head-to-head comparison with randomized phase 3 study, head-to-head comparison with auto transplant, first relapse in DLBCL, read out, p-value, and a good difference there. Similarly, Transform read out the same way. Belinda did not. So we have 2 CARs in second line, 3 CARs in third line and beyond. And real world data kind of coincides with that. This is Myeloma Consortium led by Steve Borta at Penn. And that clearly shows that intention to treat analysis, 5-year overall survival is about 37%. So very consistent, in fact, a tad better. Over a third of patients are cured with CAR-T in relapsed lymphoma. This is CIBM TR data. Data cap for this study was 2020. So basically, first 3 years after CAR approval, the field did not know how to manage CRS, field did not know how to manage non-relapse mortality. CRS, ICANS, infection, cytopenia, hypogam, all of that feeds into non-relapse mortality. Field did not quite know. So now we have better ways. Almost certainly the cure rate will be higher. So this is about 6,000 patients, 3-year survival probability over 43%. What treatment options do we have now for relapse refractory DLBCL? So first line, R-CHOP, polar R-CHP, or more intensive regimen, dose adjusted or EPOC, and so on, based on the risk stratification of DLBCL. Second line, early relapse or primary refractory disease, CAR candidate. So determine CAR candidature. If they are, move on towards one of these products. Patient is fit, nice, robust, go with Axicell. Personal opinion. Not so robust, Lisacell is the way to go, aka Breyanzi. Late relapse or transplant eligible, go with transplant. Use a salvage regimen of your choice. Doesn't matter which one you choose. Pick one and treat, take them to transplant. Some of the things on target off-tumor toxicities which kind of feed into survivorship, they survive. Some of them, long-term remissions. We have 10-year data out of Penn of CAR-T survival. So this is something that we ought to think about. Prolonged cytopenia, hypogam, put them on IVIG, monthly infusions until the IgG levels are above 400, 500. Bispecifics, we kind of do agnostic. Here we do IgG level adapted. B-cell aplasia, it's a toxicity. However, in certain clinical circumstances, it's sort of a surrogate marker of clinical efficacy of in vivo persistence of CAR. As soon as folks see B-cell aplasia kind of recovering, you know that lymphoma is about to relapse. So you start prepping for the next line. Infections, both the first two feed into infections, and then SPMs, more sort of hyped. I mean, 3 Thanksgiving ago, 2023, FDA just released that thingy. Somebody was sitting in the FDA office. Wife kicked him out of the house. He had nothing to do. He was sitting there. And then a couple of papers, case reports were published last year in NEJM. CAR, transgene getting incorporated into host genome and then causing T-cell lymphoma. And see, so every cancer drug we use, it causes SPM. What is the risk of secondary primary malignancy with lenalidomide? It's the backbone of myeloma frontline and lymphoma in many other settings. What is the risk of secondary primary malignancy with autotransplant? All of these studies have been done. It's a balancing question, whether you let your patient die or not receive effective therapy today versus worry about them dying of a secondary cancer 10 years out. So it really is a balancing question. Anyway, the risk of SPM is under 6% across the board. Disease, we can talk about disease-specific manners offline. A nice education from Mike Bishop and group in ASH, available online, open access. Psychosocial, so until REMS was removed, this was a bummer last summer. So cost, luckily, the commercial reimbursement is fantastic. Non-commercial reimbursement for CAR continues to be an issue. So there are structural disparities. By design, there are disparities in CAR access. We're not talking about Pakistan. Pakistan doesn't even have CARs. We're talking about within this. So the largest state by geography within America, half of that has 7% lower life expectancy across gender and 11% higher cancer incidence. Okay, so I'm being nudged, then I'm talking too much. I'm going to finish it real quick. So drug development and then access, right? So both need to go hand in hand. All of these drug development go into certain zip codes, certain races, certain ethnic minorities, certain poverty level, education level. So this was the paper we did with CIBMTR. It happens to have 3 of our folks here. You have Saira Baji, you have Tanya, and then the little man here as well. So we contributed to this analysis. This was by CIBMTR, obviously. Then this is a paper. This was a white paper by ASCCT platform on the downstream impact of REMS removal and how that opened doors towards homogenizing access curbing disparities, democratizing access to CAR-T. Some models that we proposed, we're still working on this. There are several mechanisms of, so one is to improve efficacy of CAR, the other is to improve access. Both needs to happen at the same time. So resistance mechanisms, so we are working on some of these things. You can design in vivo CARs, basically doing ex vivo engineering. You put that inside the patient's body and let the magic happen inside. So that's in vivo through LNP. Then you have allogeneic CARs that have some GVHD issues, CD52 knockout and stuff. Then you have T-cell exhaustion, armored CARs. You take a CAR, you armor it with a cytokine interleukin, and you chuck it in there, and it basically acts like a payload. So putative cell of origin is something that we are currently working on. Anderson and I at Texas Tech, we're collaborating very closely. We're not ready for the award yet. Just give me 10 more seconds. Award looking okay. Summary slide. So after this, there'll be key takeaways. Bunch of options. So you have multiple platform CARs, ADCs, monoclonals, bispecifics. Bispecifics are gorgeous stuff. So they're there when your patients need them, and they come really handy when you move to a place like West Texas. Half of the people can't make the flight to MD Anderson or UT Southwest Dallas. So they come really handy. Let me give you an example. You put tech on somebody whose light chains are rising, teclistamab. Once they're stable, you add daratumumab. Then they have a PFS comparable to cilta-cel. So, open questions. Key takeaways. First-line chemoimmunotherapy cures about 65% of patients with DLBCL. 30% of patients with relapsed refractory DLBCL can be cured by second or third line therapies. CAR is superior to ASCT as second line therapy for DLBCL. Non-relapse mortality, which is a pooled and cumulative function of all toxicities, is about 6% of all CAR failures. So we have to do better in terms of improving efficacy, to overcome resistance mechanisms that we talked about earlier. ctDNA MRD testing included in NCCN guidelines for PET positive DLBCL patients. Post first line treatment can be an alternative to biopsy. Not a lot of people are using it. We use it at our center, and that's sort of allows you to go non-invasive. Not formally FDA approved in post-CAR-T setting, MRD monitoring is incorporated into the expert consensus for monitoring of patients post-CAR-T. I'll stop here. We're doing some work in Pakistan as well. I'm short on time, and we can certainly discuss that offline. REMS removal curbs access toxicities, not applicable to LMICs. Thank you for your patience.